Welcome, colleagues, to today's session on infection control in the blood bank. As blood bank physicians and laboratory leaders, our clinical and administrative roles place us at a critical intersection where clinical patient care meets laboratory science. Because of this unique position, our infection control program cannot simply rely on generic hospital policies. It must be a highly specialized, active, and layered architecture. Today, we are going to walk through the essential defenses designed to preserve the clinical integrity of our blood products, while ensuring the absolute safety of our laboratory teams. In blood banking, our protocols are driven by a dual mandate that establishes two distinct protective shields. The first is the patient shield, which targets the prevention of transfusion-transmitted infections. Because our blood products are introduced directly into the vascular systems of recipients, who are frequently immunologically vulnerable, even a minor bacterial or viral contaminant can lead to severe sepsis or chronic infection. The second is the provider shield, which protects our clinical and laboratory staff from occupational exposure. Every single day, our team handles phlebotomy needles, processing sharps, and large volumes of liquid blood, putting them at continuous risk of needle sticks and splashes. Standard precautions serve as the critical breaking point in the chain of infection that secures both shields simultaneously. Understanding our biological threats requires a clear-eyed assessment of the blood-borne virus matrix, which includes hepatitis B, hepatitis C, and HIV. While rigorous donor screening has dramatically minimized these risks, the diagnostic window period remains an ever-present clinical reality for recipient patients. For our staff, hepatitis B remains an exceptionally resilient and efficient threat, capable of transmission through micro-exposures from minor sharp scratches. We must also actively guard against bacterial contamination from donor skin flora, such as Staphylococcus aureus, which is a leading cause of transfusion-associated sepsis. Because we cannot screen out every silent threat in real time, standard precautions dictate that we treat every single unit as actively infectious. This clinical reality brings us to the bedrock of our practice: standard precautions. Standard precautions are not optional, secondary guidelines. They are absolute mandates that apply to all donors and patients, regardless of their perceived health or known infectious status. We enforce this standard across our facility through three procedural and physical pillars: strict hand hygiene, targeted personal protective equipment, and meticulous sharps management. By applying these boundaries to every blood or body fluid specimen and every needle we handle, we prevent the transmission of pathogens before exposure can occur. The primary mechanical barrier in our standard precautions is hand hygiene, which we execute using two distinct clinical modalities. The first is alcohol-based hand rub, which is our gold standard for routine, non-soiled contact. Rubbing for 20 to 30 seconds rapidly denatures the proteins and cellular lipids of transient skin pathogens. The second modality is an antimicrobial hand wash with soap and water, which is mandatory whenever hands are visibly dirty, contaminated with blood, or following a suspected exposure to non-enveloped viruses. This wash requires 40 to 60 seconds of vigorous friction to physically strip and flush transient flora from the skin. Crucially, we must remember that glove use is never a substitute for hand hygiene. Hands must be clean before donning gloves, and sanitize immediately after removing them. To make hand hygiene a seamless part of our workflow, we map the World Health Organization's 5 moments of hand hygiene directly to our donor floor. Moment 1 occurs before touching the donor, during initial steps like taking a clinical history or checking vital signs. Moment 2 is our most critical aseptic window. Hand hygiene must be performed immediately before any clean or aseptic procedure, such as preparing the donor's skin and performing phlebotomy. Moment 3 is our highest exposure risk, occurring immediately after any body fluid exposure, such as stripping bloodlines or disposing of the phlebotomy needle. Moments 4 and 5 occur after touching the donor and after touching the donor's immediate surroundings, such as cleaning the donor couch or organizing the phlebotomy cart. Adhering to these 5 moments systematically breaks the transmission chain on the donor floor. When deploying our personal protective equipment, we divide our blood bank into 2 strategic zones based on risk profiling. In Zone A, which comprises donor care and phlebotomy, our primary risk comes from localized needle sticks and low-volume blood contact. Here, standard single-use gloving is the mandate, and gloves must be changed between every single donor contact. In Zone B, which covers component processing and testing, the risk profile escalates. In this zone, we handle open blood tubes, pool products, and operate centrifuges, creating significant splash and aerosolization hazards. Consequently, Zone B demands double gloving, fluid-resistant gowns, and protective eyewear or face shields to guard our mucous membranes. The requirement for protective eyewear in the laboratory is absolute, because mucous membrane exposures represent an invisible and highly dangerous pathway for pathogen entry. Unlike our intact skin, which possesses a protective, keratinized outer layer, the delicate mucous membranes of our eyes, nose, and mouth provide blood-borne viruses a direct, unhindered highway into our bloodstream. Procedures such as uncapping vacuum tubes, manipulating bloodlines under tension, or managing centrifuge spills can generate high-velocity microdroplets of blood. Standard prescription eyeglasses do not provide the necessary lateral protection, which is why protective goggles or full face shields are non-negotiable in the processing lab. Double gloving in our processing laboratory is guided by 2 clear mechanical principles. The first is the wipe-off effect. If a needle stick or sharp implement puncture occurs, the physical friction of the needle passing through 2 separate elastomeric glove layers wipes off up to 86% of the blood on the needle's surface, drastically reducing the volume of the viral inoculum transferred to the clinician's skin. The second principle is micro-tear mitigation. During prolonged laboratory procedures, gloves develop unnoticed micro-tears from physical stress. The mathematical probability of 2 micro-tears perfectly aligning on both the inner and outer glove is virtually 0, making double gloving our most reliable defense against silent exposure. Even the highest-grade protective equipment will fail if our removal technique is flawed, as improper doffing can easily turn contaminated gear into a transmission vector. To prevent self-contamination, we must follow a strict, slow doffing cycle. We begin by removing our gloves, pinching the wrist and peeling them inside out so the contaminated surface is contained. Next, we remove our goggles or face shield from the back, ensuring we never touch the highly contaminated front surface. We then unfasten and roll our gown away from our body, touching only the clean inside of the fabric. Finally, we remove our mask and perform thorough hand hygiene to neutralize any accidental transfer that occurred during the process. Despite rigorous training, perfect protocols, and layered physical barriers, mechanical failures and accidents can still occur in a high-volume clinical laboratory. When an occupational exposure does happen, the most dangerous systemic failure is hiding or delaying the report due to fear, embarrassment, or an assumed low risk. Our facility maintains a designated, fully staffed nodal center that operates 24 hours a day to provide immediate clinical triage, counseling, and rapid access to prophylaxis. Reporting an exposure is not a sign of carelessness. It is a vital act of professional and clinical responsibility that protects your health and the safety of our entire team. If an exposure occurs, your immediate actions in the first few minutes, the golden hours, are critical to reducing pathogen absorption. For a sharps or needle stick injury, immediately wash the wound under running water with soap. Do not squeeze, milk, or scrub the wound, as this induces localized hyperemia and negative pressure, which can actually accelerate the systemic absorption of viral pathogens. For skin splashes, wash the area thoroughly with soap and water. For eye or mucous membrane splashes, flush extensively with copious amounts of water or sterile normal saline for several minutes. Secure the area, perform these first aid steps, and report the incident immediately. Once immediate first aid is complete, the formal exposure management pathway begins. We immediately report the incident to the infection control officer and log it in the occupational exposure register. We then rapidly evaluate the source donor, performing rapid diagnostic tests for hepatitis B surface antigen, anti-HCV, and anti-HIV. Concurrently, we assess the exposed healthcare worker's baseline, checking their hepatitis B vaccination history and antibody titers, and drawing baseline serology. A physician from our nodal center then conducts an immediate clinical triage to determine the necessity of pharmacological post-exposure prophylaxis. Our post-exposure prophylaxis protocols follow 3 distinct therapeutic pathways based on the pathogen involved. For hepatitis B, if the worker is unvaccinated or a known non-responder, we administer hepatitis B immune globulin and initiate the vaccine series within 24 hours. For HIV, if indicated, we initiate a 3-drug antiretroviral PEP regimen as quickly as possible, ideally within 2 hours and strictly within 72 hours of exposure, continuing for 28 days with serial follow-up serology. For hepatitis C, there is currently no approved pharmacological PEP. Instead, we rely on baseline testing and early molecular monitoring to catch and treat acute infection with direct-acting antivirals. The lack of an HCV PEP underscores why our physical barriers are so critical. In conclusion, we must recognize that no single layer of our infection control system is completely impenetrable. Gloves can develop microtears, blood splashes can happen, and pathogens will continue to present clinical challenges. Our defense architecture relies entirely on the continuous stacking of these deliberate, repetitive microactions. By consistently executing meticulous hand hygiene, deploying targeted personal protective equipment, and adhering to rapid reporting and post-exposure protocols, we seal any potential breaches in the chain. In the blood bank, an uncompromising culture of occupational safety is the ultimate foundation of patient safety. Thank you for your time, and I am happy to open the floor to any clinical questions.